you very much. This is that's a hard act to follow, and I have a software product, so my slides are not very. I don't have any arms or legs, but I just want to brag on Kim for a second. I'm not talking about any products that Kim has worked with me on today, but there are two products that she has worked with us on, my daughter and I. And I would thank Tom also for his work, but and one of those is very close to market. It's called a therapeutic percussive pillow. You'll love it. But today, the product that I want to talk about is an electronic board for labor and delivery. So I'm seeing all these experts in the room about labor and delivery, and I'm sure they're thinking another man telling us about labor and delivery. So I recognize the experts in the room. I honestly do. And the other thing I would just mention is that this collaboration with Wichita State was not with Kim and Tom, but rather with the Department of Human Factors Psychology. They're my new heroes. They're unbelievable, and we heard very early about possibilities and needs, and that is where these people can really help you. There's lots of possibilities, like engineers can make anything, but Human Factors has been instrumental in developing this product, and Dr. Barbara Shapiro has been intimately involved with this development. I would thank also Mr. Volich, one of my bosses, one of my three bosses. Two of the three are here. Dr. Menz is the dean of the medical school, and my wife is not here. So, but Mr. Volich has helped us immensely in putting this product at Wesley Hospital. So just to bring it into perspective, labor and delivery units are wild. They're unpredictable. They're not scheduled. Women will have babies when they will. At Wesley, every person that shows up at the hospital that's greater than 20 weeks ends up in labor and delivery for evaluation. So there's a wide range of patients that are seen in labor and delivery. And the challenge is there's no schedule. They just show up when they will. When they show up in labor and delivery, there is a team of individuals that are helping to take care of them. Every patient, of course, has a nurse assigned to them individually. But in the background, there is a team that is taking care of that whole unit. So instead of thinking about just one patient, think about the unit, this labor and delivery unit at Wesley Medical Center, 6,500 deliveries a year. So there is 20 people. When we look at this, there's probably 15 to 20 people in labor at any given time right now. And those patients are taken care of by their attending physicians, but on the deck, you have resident physicians, usually first-year OBGYN residents, you have nurse managers, and you have anesthesiologists. So the product that I'm describing those are the constituents that we're working with. They have to talk to each other, and over time, to get a global view of the unit, this is what has evolved. This is a de-identified picture of the labor and delivery board at Wesley Medical Center on a typical day. Now, I would point out to you that this is a whiteboard, and whiteboards come with a lot of colors, and whiteboards come with a lot of people. And so you can see, like, I can't see it too well from here, but for instance, infant's doctor name. I can assure you that nothing written in that column is the name of an infant doctor, but it has something to do with something related to the patient. So my point is that the flexibility of this is incredible. Okay, so the doctors in the room are gonna, I'm old, okay, I'm gonna lie and say. So written words, things that you write down, we are very used to that. And we were told a lot of things about electronic medical records. Now, if you did a Snopes on this, you would see that these are all lies. All of them. These are lies. So that's my skeptical look. So none of this is actually true. So, but my point is that when I come to replace this whiteboard that you saw with something that is electronic, this is a barrier for me because none of this has been true before. This is what doctors and nurses look at when they see a patient and a blank piece of paper. Okay, this is how it looks. And when you take that, lots of things can happen. Lots of different ways to record data, lots of different ways to make art. But that's not the way it works with electronic medical records. Everything goes into a box. Free text is the enemy of electronic medical records because it's not searchable. So everything gets put into a box, and I am writing a paper right now with a friend of mine at Duke. It's called The Death of Learning, the perfect storm of EMR's practice guidelines and order sets. So right now, there's little variability. If you come into the hospital with pneumonia, there's a pneumonia order set. There's order sets that have been put in place by following practice guidelines by professional organizations. So it's a barrier. So we face this little battle. The whiteboard is infinitely modifiable, but the key factor, you might say, why did it evolve? And the answer is there needs to be a central place where you can see the whole picture of the unit, however many people are there. And you have to have some way to look at that and say, these are sick, these are doing okay, these are progressing normally, these are not. What am I going to do with this information? The problem with the whiteboard, it's a static snapshot. You only see right now what is happening. You don't see what has happened in the past. So you would have to know. I mean, you would have to remember. So these are first-year residents, and you have 20 patients in labor. How long has Mrs. Jones been 4 centimeters? I don't know. I can't remember. So these are, and then the last thing is that this data, when these patients are dismissed, it's erased. It's gone. So there's nothing captured. So the O-board has structured entry forms, and it has still provides a global view. It has saved the data into local repositories, and then we plan to have data sharing agreements with hospitals to upload de-identified data into registries. Registries are very, very powerful. We are a software company. I mentioned that. It's formed by obstetricians. Our goal is to improve healthcare of women, specifically in the labor and delivery, improve workflow, improve communication. Ultimately, this will be a bi-directional communication. The product will be distributed mobily, and information can come back to the board mobily. And Dr. Shapiro is working on those interfaces right now. Dom Canaris, I misspelled his name, started the prototype a couple of years ago, and then we hung this board in Wesley on March of 23rd of this year, and it has been functioning outstandingly. I called the technical support guy last night to make sure I wasn't lying, and I am. He had one call in the last month, and the board was slow, and they rebooted the computer, and it was fine. So I lied. Sorry. This is just a couple of pictures of what the board looks like. One last point that I want to make is about patient safety. Transitions of care are opportunities for errors. One of the things, so in fatigue management with residents now, there are duty hour restrictions, and so we used to do 24-hour shifts in labor and delivery. Now they do 12-hour shifts. Guess what? You just double the number of handoffs. Handoffs are where problems occur. So we have, this is again with Dr. Shapiro, we have created a handoff form. So every 12 hours, the residents will open the handoff form on a separate electronic board, and they will systematically go through every patient on the board, presented with the information over here, and then they can add tasks that they need to do, add comments that need to be made, and all of that goes back to the board. And the data is entered by forms, so it's a click, click, click. This is a labor curve, so it does track historically the labor. So you can open this up on any individual patient and see the labor curve. You can manage abnormal labors. You can send patients home that aren't in labor. And this is just, so we are at this place, whoops, that's the wrong one. We're at this, I don't care about that one. We are here right now. So it's a standalone system right now. We're not integrated with anything in the hospital. We've been to several other sites, and I love that fact that it's a standalone system, but it does mean double data entry, and there's kind of a pushback on that. So I think that this product is going to eventually land into some interface with the EMR that will pull data into the board and stop duplicate data entry. And this was just at a show that we were at. And this is the team that we have right now. We've just added a couple of programmers. I'm just going to throw out one last thing. This is Robson Parzinello, is a Brazilian. Brazil is a hot market for us. So Brazil, I don't know if you all know this, but the C-section rate in Brazil for private payers, 90%. For public payers, it's 50 to 60%. Okay, the C-section rate in the United States right now is 32%, and it needs to go down. So hopefully one of the benefits of this product is to lower that primary C-section rate by identifying abnormal labors. And in Brazil, this is all prospectively entered data, so nobody can go back and say, well, this happened or that happened or whatnot. So, and I believe that is my last slide. Thank you very much. Be happy to answer any questions. Yes, sir.
Yeah, I was glad that you brought up about human factors psychology. Can you be more specific about what Dr. Shapiro did and towards your project?
So anytime any interface with the user went through her hands. So like all the forms that I showed you, all of the forms there was an iterative design process with her and I really. But she has had all the input in. We're still missing a couple of things. Like I showed that picture of the board, and there's some things that she suggested color-wise that need to still go on the board that probably are going to go on. But really, she has been instrumental in what the user needs to see and how they see it and how they will intuitively place the data where they'll place it. And she's doing the mobile apps, the screens for the mobile. Obviously, you can't put this on a.
Have you been involved in testing it?
Pardon me?
Have you been involved in testing it?
It's in use at Wesley for 2 months.
So was there, some research done on testing its use?
Yes. She's done a lot of time studies. There's a lot of research she's done with it.
I love the product. I hate the placement. Is there that little skinny hallway where everyone goes and looks at that board, and the cleaning ladies go by, and the nurses go by, and the residents and anesthesia? Do you have something in mind where you could make it like the residents could update it from their phones, or where we're not all clustered around the board?
And that's the part that we're working on now, is the mobile distribution. So you can't distribute the whole board to a phone. You can't see it. It's huge. So Dr. Shapiro is working with us on distributing like specific room data. So the answer to your question is yes, and it will also be distributed to computer terminals in labor rooms, or computer terminals at the desk. Obviously, to be HIPAA compliant, you have to have this in a location where it's not visible to the public. But yeah, the little hall, I didn't really spend a lot of time showing that, but for those of you that have been in that little hall, it gets pretty crowded around the board. But this is where everything happens in labor and delivery, is at this board. But you're right. You can almost envision a time where nobody would have to go to the board using mobile device.
Last question.
Well, thank you. As a former labor delivery nurse, I remember blackboards before the whiteboards.
Right.
But anyway, but I'm really the handoff thing intrigued me a little bit. And is there anything thinking about even other places within the hospital with using that as a handoff kind of thing? Because that's a real problem.
Yeah. So this board is designed for stability, number one, and for interoperability. So these are rows and columns that can have any name that you wish. So you could use this in a cath lab, or you could use this in an endo suite or a surgery center, or anywhere a patient comes in, has a team work on them, and leaves. This is perfect for any situation like that.